Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about wart. Definition: warts are benign neoplasms caused by infection of epidermal cells with papillomaviruses. The thickening of the epidermis with scaling and an upward extension of the dermal papilla containing prominent capillaries give them their warty or varicose appearance. Incidence: warts generally occur in healthy children and young adults. Genital HPV infection may be the most common sexually transmitted disease. Of sexually active adults, 1% are estimated to have genital warts, and a further 10 to 20% have latent infection. For sexually active young college women, the incidence of infection is high, 43% prior to the advent of HPV vaccines. Some 5 to 7% of patients seen by dermatologists present with warts. History: predisposing conditions make the occurrence of multiple warts more likely. Immunosuppressed patients, such as renal transplant recipients, are prone to the development of warts. Inquiry into the patient's occupation is important because butchers and meat cutters have a significantly higher incidence of common warts. Genital warts or Condyloma acuminata affect sexually active individuals, and their occurrence in children should raise suspicions of sexual abuse. However, most patients with warts do not have any significant predisposing conditions. Physical examination: the common warts or Verruca vulgaris is a flesh-colored frame papule or noodle that has a corrugated or hyperkeratotic surface. It interrupts the normal skin lines and is studded with black puncture, which represent thrombosed blood vessels. Common warts occur individually, in groups, or in a linear fashion from auto-inoculation. The hands and fingers are the usual size. Involvement around nails frequently results in extension underneath the nail plate. A Filiform variant of Verruca vulgaris occurs on the head and neck. Wart scaling: varicose papules, plaques with interrupted skin lines and black puncta. Wart: thickened epidermis with overlying hyperkeratosis. Vacuolated keratinocytes are present in the granular cell layer. A flat wart has a subtle appearance. It is a flesh-colored or reddish-brown, slightly raised, flat surface, 2 to 5 mm well-marginated papule. On extremely close inspection, a hand magnifying lens may be needed. The surface appears finely varicose. Multiple lesions commonly affect the hands and face. A linear arrangement of lesions is common. Flat warts: pink flat papules in a linear arrangement suggesting auto-inoculation. A plantar wart may occur as a single painful papule on the plantar aspect of the foot. It is often covered by a thick callus. When the callus is pared down with a scalpel, the underlying wart is visualized with interruption of skin lines and black puncture. Multiple plantar warts may coalesce in a mosaic configuration or remain discrete in a mother-daughter relationship with a central large wart surrounded by multiple smaller warts. Note: common and plantar warts interrupt skin lines and have black puncture. Plantar warts: confluent varicose plaque. Venereal anogenital warts or Condyloma acuminata involve the rectum, perineal region, inguinal folds, external genitalia, and occasionally urethra and vagina. This wart is composed of a soft, moist papule and plaque that may be sessile or pedunculated. It has a varicose surface that is often cauliflower-like. Soaking the genital area for 5 minutes with 3% to 5% acetic acid or white vinegar causes warts to turn white. Subsequent use of a hand magnifying lens or colposcopy enables better visualization of small genital warts. Acetal whitening. Although acetal whitening increases the sensitivity of detection, it is not specific for HPV lesions and is not recommended for routine screening because our diagnosis of external genital warts may occur. Genital warts, varicose, flesh-colored papules on the genitalia. Differential diagnosis. A common wart usually is easily recognized. When covered with a thick scale, it may be confused with a callus, which on pairing does not have interrupted skin lines. The diagnosis of squamous cell carcinoma should be entertained for a lesion that is resistant to treatment, is enlarging, and is crusted or ulcerated. A flat wart on the face may be confused with a non-inflammatory acne lesion, the whitehead or comedo. The tops of comedones are smooth and dome-shaped, whereas flat warts have rough and flat tops. When flat warts occur on the hand and forearm, lichen planus and idiopathic inflammatory skin disease is in the differential diagnosis. Lichen planus papules are red top purple, warts are flesh-colored. Plantar warts and corns are often confused because both are painful and have a thick scaling surface. However, paring down the surface demonstrates the interruption of skin lines and black puncture characteristic of a plantar wart. Genital warts may resemble the varicose form of squamous cell carcinoma. Lesions that do not respond to treatment must undergo biopsy. Secondary syphilis of the anus and genitals or condyloma latum is ruled out with a Dagfeld examination and serology. Seborrheic keratosis in the genital region also may resemble venereal warts. Boenoid papillosis is an uncommon disorder characterized by erythematous, sometimes pigmented papules occurring in the genital region of sexually active young adults. Histologically, boenoid papillosis has the appearance of squamous cell carcinoma in situ. Its relationship with HPV infection has been confirmed by finding HPV DNA in boenoid papillosis, especially HPV-16. Conservative surgical modalities or topical therapies should be used to treat boenoid papillosis. Radical modulating procedures are unwarranted. The conclusion of differential diagnosis of warts include common warts, callus, and squamous cell carcinoma, and for flat warts, comedo and lichen planus, and for plantar warts, corn, and for genital warts, squamous cell carcinoma, secondary syphilis, seborrheic keratosis, and boenoid papules. Laboratory and biopsy. Warts are usually not biopsized unless a suspicion of carcinoma exists. When examined by biopsy, warts demonstrate a thickened epidermis or acanthosis with overlying hyperkeratosis. Distinctive large keratinocytes or koilocytes with small pyknotic nuclei surrounded by clear cytoplasm are found in the upper layers of the epidermis. Typing of HPV is based on DNA homology. Therapy. Prevention of warts is better than treatment. A quadrivalent vaccine or Gardasil preventing types 6 and 11, which cause anogenital warts, and types 16 and 18, responsible for more than 70% of cervical cancers, is highly effective for young males and females. Treatment of warts is non-specific, destructive, and usually painful. A topical local anesthetic applied under occlusion 1 to 2 hours before painful procedures may be beneficial and when treating warts in uncooperative children. The goal is destruction of the keratinocytes that are infected with HPV. This may be accomplished with a variety of physical, chemical, or biologic modalities. The physical modalities include cryotherapy with liquid nitrogen, electrodesiccation, and curettage, surgical excision, and laser therapy. Cryotherapy, the most common initial mode of treatment, uses either a cotton-tipped stick or a cryospray unit to apply the liquid nitrogen onto the verruca. A white ice ball develops at the site of freezing and should extend 1 to 2 mm beyond the margins of the wart. After the error has thawed, a second freezing results in greater destruction of the wart. Subsequent blister formation often occurs within 24 hours. After a couple of weeks, the blister dries and the skin containing the wart peels off. Often follow-up treatments every 4 to 8 weeks are necessary to eradicate any residual wart. Eradication generally requires at least 2 or 3 visits. The advantages of cryotherapy are that it is quick, does not require local anesthesia, and the discomfort from the freezing is tolerated well by most patients, except young children. Caution must be used with all the physical modalities, especially surgical excision, because of potential scarring. The scar may be cosmetically unacceptable, or it may be painful if on the plantar surface. Although laser surgery was initially thought to be superior to other surgical procedures in removing warts, this now appears not to be true. Numerous chemotherapeutic agents are used to treat warts either in the office or at home. The initial treatments include salicylic acid at home or trichloroacetic acid in the office. Common warts may be treated with non-prescription 17% salicylic acid preparations applied daily with or without occlusion or duct tape. The wart is softened by soaking in water for 5 minutes before application. Any loosened tissue is gently removed. Once the acid has been applied, the wart can be covered with adhesive tape. Cryotherapy, a potent blistering agent derived from the blister beetle, is an alternative office treatment that is applied to common warts and covered with tape. After 24 hours, a blister forms beneath the wart. The blister roof dries and peels off, taking with it the wart. Occasionally, cryotherapy or cryotherapy may result in the formation of a new wart in an annular configuration or ring at the periphery of the blister. Plantar verruca are treated with daily application of a 40% salicylic acid plaster or 17% salicylic acid liquid under occlusion or duct tape. Genital warts are commonly treated with 25% polyethylene resin or Protocol 25, which can be very toxic and is used only in the clinician's office. Within 4 to 6 hours after application, excess polyethylene should be washed off to prevent excessive local irritation. Caution must be used when applying polyethylene to extensive lesions because severe systemic reactions may result from absorption. The Centers for Disease Control and Prevention prefer cryotherapy over polyethylene for the treatment of genital warts. Polyethylene is a cytotoxic agent and has resulted in renal toxicity, polynephritis, and shock. Polyethylenes must never be used during pregnancy because of potential harmful effects on their fetus. Polyethylox, a chemical pair ligand derived from polyethylene, is available as a 0.5% topical solution or gel for patients' self-treatment of external genital warts. Application is made twice daily for 3 consecutive days, followed by a 4-day rest period. This cycle may be repeated up to 4 times. Cyanocatechins, 15% ointment or Verruca is an alternative treatment. The sexual partners of infected individuals should be examined for the presence of genital warts. Female patients with genital warts should have periodic gynecologic examination with papinicular smears. Screening for other sexually transmitted disease should be considered. Children greater than 4 years old with genital warts should be screened for sexual abuse. Genital warts in children under 4 years old are typically acquired from a non-sexual transmission. Recalcitrant warts have been treated with 5-fluorouracil topically, bleomycin intralesionally, and interferon topically, intralesionally, and systemically. Biologic treatments have centered on the induction of immune responses. Imiquimod cream 5% applied topically induces the cytokines interferon alpha, tumor necrosis factor alpha, and interleukins 1, 6, and 8. It is indicated for the treatment of external genital and perineal warts with 3 applications per week. Squaric acid dibutylester has been used to induce allergic contact dermatitis. Presumably, the wart is destroyed by the delayed hypersensitivity reaction that occurs at the site of application of their allergens. The conclusion of therapy for warts: the initial therapy included cryotherapy with liquid nitrogen for all warts and salicylic acid plus occlusion with tape for common and plantar warts, cantharidin especially for children, tretinoin 0.1% cream for flat warts, podophyllin 25% for genital warts, and podophyllok solution or gel for genital warts twice daily for 3 days per week for 4 weeks, and imiquimod cream for genital warts once daily for 3 days per week for 16 weeks. An alternative therapy includes surgical excision, curettage, and electrocautery, laser interferon, bleomycin, intralesional fluorouracil, cyanocatechenes 15% ointment for genital warts 3 times daily for 16 weeks, and squaric acid. Cause and complications: a total of 35% to 65% of warts resolve spontaneously within 2 years. Treatment results in cure rates or as high as 80%. Of concern is the relationship between papillomavirus and carcinoma. Papillomavirus-associated cancers occur in humans, cattle, horses, and rabbits, and experimentally in rodents. In patients with the rare syndrome epidermodysplasia verruciformis, manifest by widespread refractory warts who are infected with HPV-5 or HPV-8, sun-exposed flat warts progress into squamous cell carcinoma. Furthermore, HPV genomes have been demonstrated within their malignant squamous cells. The evidence for mucosal papillomaviruses types 16 and 18 causing cervical cancer is overwhelming. HPV infection of the cervix appears to represent a necessary but not sufficient condition for developing malignancy. Other possible cofactors such as cigarette smoking appear to be required for carcinogenesis. HPV typing, however, has not been proven to be beneficial in their diagnosis and management of external genital warts. Note, mucosal papillomaviruses type 16 and 18 are the leading cause of cervical and anal carcinomas. Pathogenesis: the papillomavirus is a double-stranded DNA virus that infects and replicates in keratinizing cells in their epidermis. The HPV virion is an icosahedral particle composed of a viral genome surrounded by a proteinaceous capsid. Progeny HPV virions are assembled and become apparent in the upper layers of the epidermis, especially the stratum corneum and stratum granulosum. Viral genomes are found in the lower layers of the epidermis and probably help to explain their chronicity and treatment failure of many warts. The presence of the wart virus stimulates epidermal proliferation, resulting in epidermal thickening and hyperkeratosis. Papillomaviruses have been subdivided into distinct types based on DNA homology. On this basis, more than 150 genotypes have been described. The clinical type of wart had been thought to be determined by local conditions at the site of infections. However, it now appears that different HPV types are responsible for the different clinical lesions, common, flat, plantar, and genital, because good correlation often exists between clinical presentation and HPV type. Clinical case: a 16-year-old boy presents with a rough bump on the dorsum of his right hand that has been present for 4 months. The lesion is painless, but he is concerned because it has gradually increased in size. On examination, there is a firm hyperkeratotic pupil with a rough varicose surface. Small black dots are visible within the lesion. Pinpoint bleeding occurs when the surface is paired. There are no similar lesions elsewhere. Which of the following is the most likely diagnosis? A. Corn or clavus. B. Lichen planus. C. Verruca vulgaris or common wart. D. Seborrheic keratosis. And E. molluscum contagiosum. According to our explanations, the correct answer is C. or Verruca vulgaris or common wart. Explanation. Verruca vulgaris is caused by human papillomaviruses, HPV, especially types 2 and 4. Lesions are rough hyperkeratotic papules, often showing black dots or thrombosed capillaries, commonly found on fingers, hands, elbows, and knees. Pinpoint bleeding when paired is a classic sign. Differential points. Corn located at bony pressure points, painful on direct pressure, no black dots. Lichen planus, flat top, violaceous papules with wickhamsteria. Seborrheic keratosis, waxes stuck on appearance, thummus or warty surface, and molluscum contagiosum. Dome-shaped papules with central amplification and cheesy core. Okay, this was an explanation about the different types of wart. Thank you for your attention.